How are you preparing for your exams in NCLEX? How are you approaching questions when you see them? The NCLEX, it's a board exams. They're going to test your knowledge. They're going to test your stamina. They're going to test your understanding of the content. They're going to test your safety. If you figure out what they're asking you, the rest of the answers are easy. And then let me show you how I approach questions in adaptive NCLEX. Which client situation require immediate information? After reviewing the following test results, DUN 25 for a client with pyloric stenosis who is receiving saline infusion, normal saline. Hemoglobin of 8 for a client with sickle cell who is receiving blood transfusion. WBC of 18,000 for a client with asthma who is receiving IV steroid. And a phosphorus of 2 for a client with anorexia who is receiving TPN. Prioritization 101. You have to think whether it's a breathing issue, electrolyte shock, sepsis, airway, neurological problem, or pain issue. You may not see that, and then you have to think about what you need to do for the patient if you have 1 second. You have to change the answer choice in the form that if I have 1 second, who am I going to see? Don't go with the words. The words in the question, the diagnosis, don't go with it. It's a trap. Key, situation. What is the situation? That is the prioritization. That's how we take care of the patient. The situation always changes because you can have congestive heart failure and you'll be normal. Not every day you get into trouble. You're going to be normal. So, which of this is the most important? And look at the way I'm going to break it down. Your BUN is what? What is your BUN? 24, 25. If your BUN 25, why? I have pyloric stenosis. Why? Because probably I'm vomiting. Diagnosis. Therefore, I'm dehydrated. If I'm dehydrated, I'm receiving normal saline. What else you want to do for me? Nothing. Don't get trapped with the normal. So you don't need to do anything for this patient. He has pyloric stenosis, he's vomiting, his BUN and creatinine is up, so he's dehydrated. We're giving them normal saline. Nothing in the question should be worrisome. Hemoglobin of 6. Why? Because I have sickle cell. And I'm anemic because I'm sickle cell, right? What is happening to me? I'm being treated with what? Blood transfusion. I never tell you the patient is in crisis, is about to die, pulmonary crisis, chest crisis. No. Hemoglobin of 8, are you taking care of it? Yes, you're giving them blood. Test taking strategy, adapt the NCLEX way. WC of 18,000, I have asthma, and I'm receiving steroid. Steroid, one of the signs and symptoms is leukocytosis. When you're on steroid, your white count goes up. You have asthma, that's why you get steroid. And your white count is going up. You have no infection. There's no infection there. It's the signs and symptoms of one of the leukocytosis. Basically, it causes leukopenia. And these blood cells, they are not functioning the way they're supposed to because it causes early migration of neutrophil, its content. Steroid will make your white count goes up. Test taking strategy. 1, 2, 3 is gone. If you pick number 3, it's wrong. If you pick number 2, it's wrong. If you pick number 1, it's wrong because these are all expected findings. We have to be sharp, not unexpected. Therefore, number 4 is the right answer. Why? Your phosphorus is 2. You are anorexic and receiving TP. Remember, anorexic patient Potassium, magnesium, calcium, and phosphorus are low. When they come in, all of these are low. When you start feeding them, they go low, low, low. And you have to watch for their phosphorus. If it's too low, respiratory failure. They go into cardiac arrhythmia, fluid overloaded. That is refeeding syndrome. Phosphorus is too low, it's going down. If you check lab again, it will be like 1.5. This patient, I don't like it. Look like he's getting refeeding syndrome. Test taking strategy and content in this guys. So number 4 is your right answer. Okay, so number 4 is the patient which you see. I don't like it in an anorexic patient. O phosphorus is that low. When on TPN, it should be going up. Number 2, which of the following does the nurse anticipate in the care of this client patient? What do you think? A client presents to the emergency room. This is the finding. Dry mucous memory, tachycardia, blood glucose of 300, pH of 72.4, serum potassium 5.6, and he has deep, rapid respiration. Test taking strategy, adapt and clear way. Make the diagnosis. Don't look at the answer choice. Don't worry about it. If you don't know this, you can answer that. Find out what examiner is trying to ask you. What is all these bunch of words I've given you? What am I trying to do? What is the point? What is the point at all? Have I given you this? What am I trying to give you? Yes, DKA. If that's the problem, how do you treat it? 3% normal saline, 5% normal saline, 0.9% normal saline, 0.45% normal saline. Think about it. What do you want to give this patient? Patient is dehydrated. What fluid will you want to choose to give it to that patient? Think about it. You see, the question is not hard. You make the diagnosis, you know that this is DKA. Therefore, what am I going to give this patient? What do you think? 3%, 5%, 0.9%, 0.45%. What is the fluid for resuscitation? What do you think? 0.045 is not a good fluid for resuscitation. 3% is not a good fluid for resuscitation. Neither is 5%. You're just giving them sodium. They need fluid. The best solution is 0.9, 1% normal saline. It's what is effective for fluid resuscitation in this patient. Therefore, number 3 is your right answer. So that's that one. But you have to make a diagnosis fair. You see what I did? I have 5 questions, different variety of thinking to figure it out. And this may be difficult for some people. But don't make it. Look for the buzzwords. Focus on the buzzwords. And use that to answer the question. Which of the following does the nurse expect? I expect this. One buzzword here. The nurse is caring for a client admitted for what? Nephrogenic, diabetes, insipidus. What do you think? Nephrogenic, diabetes, insipidus. Which of the following the nurse should expect? Low serum osmolarity, urine specific gravity, no change in urine output with desmopressin administration, and decreased test. Think about it. Break it down. You got to figure out what is nephrogenic diabetes insipidus is your buzzword. And when you figure out what do I expect, that's all. rewrite the question your own way. Nephrogenic diabetes insipidus. When you're taking the test and you said, hey, every time I see diabetes insipidus, they don't write it. They just write DI. All of a sudden, this one is saying nephrogenic diabetes insipidus. That means there's a reason why the word is there. There's a reason why there's nephrogenic diabetes insipidus. And so if you don't know, then you have to learn about it. There's a nephrogenic and there's a central diabetic insipidus. I told you it's nephrogenic. You have to define it. What do you expect in diabetes insipidus? There's no ADH. And therefore, what? Your serum sodium is high. Serum osmolarity is high. Serum urine osmolarity is low. Urine sodium is low. And you're losing a lot of water. But why did I put nephrogenic diabetes insipidus? It's a content. What is nephrogenic diabetes insipidus? You know that this is what I'm going to expect and if I have DI. Therefore, you can see that 1, 2, 3, and 4 are all wrong. But let me show you. If you have nephrogenic diabetes insipidus, you have ADH. But when you go to the kidney, there's nothing. Kidney couldn't recognize it. The kidney does not recognize it at all, even though you have ADH. And therefore, you act like diabetes insipidus, but because it's not because you don't have ADH, it's because the kidney does not recognize it. Okay? If you have no ADH, your serum osmolarity is supposed to go high. Therefore, this is wrong. Your urine specific gravity is not going to go high. It's going to go low. You're going to get dehydrated. And you'll be thirsty. Even if you don't know what that nephrogenic diabetes insipidus, I just took the nephrogenic and I used diabetes insipidus. And now you see I've eliminated 1, 2, and 4. And I'm left with this. And that is your right answer. Then you say, well, if you have diabetes insipidus, if I give you desmopressin, your urine output should decrease. But I told you, nephrogenic diabetes insipidus, if you give me desmopressin or ADH, the kidney cannot see it. So yes, no change in your urine output with nephrogenic diabetes insipidus. So this is the right answer. It's a test-taking strategy, thinking question. And that is the only way you'll be able to answer the question. Like, you know, DI, your serum osmolarity is going to be high. You know your urine specific gravity is going to be low. You know you're going to be thirsty. Therefore, 1, 2, and 4 are wrong. I don't understand number 3. I have no clue. I can't explain it. But when you're using test-taking strategy, you're thinking based on your content. You don't know the answer, but if you use your content that, oh, 1, I'm 100% sure 1, 2, and 4 is wrong. Therefore, I have to pick 3. Yes, it's a nephrogenic because the desmopressin or ADH the kidney is not responsive for that. So it cannot absorb it. It cannot use it. They will act like diabetes insipidus, but the kidney cannot recognize it. That is the way you can distinguish it between nephrogenic and central, because ADH cannot work in this situation. What defense mechanism the client is exhibiting, right? A nurse is caring for a client admitted for what? Stage 3 colon cancer. Client had a family meeting about his wishes. Client and the main meeting abruptly with the family. Client later became abusive verbally to the nurse of underlying device rate. Diagnosis colon cancer. Had a meeting with the family. end the meeting abruptly, now being abusive to the nurse. What defense mechanism it is? It's straightforward, right? How do you answer it? You got to define this. And don't get trapped. Define it in the precise, concise way. Don't use too many words. Don't use too many words. Okay, if you use too many words, you get it wrong. Colon cancer. Had a meeting with the family. Now, me abusive to the nurse. Verbally. What do you think? I'm not projecting. This is not projection. Projection, like there's multiple examples you give. You did something wrong and you say somebody did it. You projecting. Secondly, okay, you are somebody bad. You said the other person is the one that is bad. Third, you go to a grocery store and you know you are the thief. You tell the owner that there's a thief standing there. That's you projecting. So you did something wrong and you said, hey, your friend did it. You're blaming them for it. Or like you are a surgeon. You're a surgeon. You did a surgery and there's complication. What happened? You blame the assistant as the problem. That's projection. What you are, you're telling your action, your inner feeling, you're projecting on somebody else. It can be no matter. What is not reaction formation? Reaction formation is you have really bad feeling inside, but you're acting opposite that. You hate your friend, but when you see them, you are high-fiving, you're loving each other. That is reaction formation. You're reacting to that formation. Sublimation is different. Okay? They sound confusing, but you have to define it precisely. You have bad, unacceptable feeling, but you turn it into good. It's not like I hate you, then I'm loving you. That is not sublimation. The bad feeling I turn into good, like sexually abused, but then you're an advocate. Your father beat you all the time. You became a boxer. You turn into something socially acceptable. That is sublimation. There's taking strategy. This lady, patient, client is displacing the anger he or she had with the family during the family meeting. Is now displacing it on the nurse. The nurse who has done nothing. That is displacement. So I'm displacing it to the nurse. If you want to learn how to do that, I have a video on defense mechanism free of charge. You can watch it. You will love it. Okay. Number 5. Let's do this. Straightforward, right? What defense mechanism the client is exhibiting? The client kicked his son out of the house after finding out of a new cancer diagnosis. 24 hours later, client bought a Tesla for the son. What is he doing? He found out that he has colon cancer. He kicked the kid out. 24 hours, he bought a Tesla for the kid. What has he done? Is he projecting? Is he reaction formation? Is he sublimation? Or is he undoing it? I love this question because it's a classic way we do that. You beat your kid and then you bought chocolate for him the following day. Right? That's you mad at your spouse, then you bought flowers. Right? Yes. He bought flowers to you so that he can do what? Undo what he has done. The bad thing he has done is undoing it. Undoing is not the same as sublimation. Like I said, sublimation, I'm transferring the unacceptable feeling into a good one. That is not undoing. Reaction formation, I'm acting opposite to my feeling, projecting my bad feeling. I'm projecting on you. But undoing whatever I've done wrong, I'm going back actively trying to undo it, turn it into right. So when I kick you out, I went and bought a Tesla for you to undo the thing I've done. I hate it. I don't like what I did for kicking you out. So I'm like pacifying you. Undoing, another way to see it is to say, I'm pacifying you. You beat your kid, you bought a chocolate for him. You and your husband had an argument, he bought a flower. It was wrong. He bought a flower to pacify you. That's you undoing the wrong thing. But you have to be actively do that. It's not like you acting opposite to your feeling. Your feeling was there, but you want to just like undo it completely so that that person is okay. This is adapting class. Thank you for watching.